I have the honor to present Dr. Mohamed Loutfi and a lecture about optimizing the dose of maximum protection.
Good afternoon, good evening, everybody. Mr. Chairman, dear colleagues, it's my pleasure to share with you this session about the role of ACE inhibitor in the management of heart failure.
صوت يا دكتور محمد مش سامع. صوت.
The guidelines, in this session, we're going to discuss the guidelines, the recommendation for heart failure, the optimal doses for heart failure management, the randomized clinical trials, does high dose show benefit over the ordinary or low dose, and what is the ideal up titration?
ممكن تقرب المايك شوية.
What is the ideal up titration method for heart failure management? First, the guidelines for heart failure management. As we all know, there is still a role of ACE inhibitor in the management of heart failure, even in 2020. The last guidelines of European Society of Cardiology recommends the use of ACE inhibitors is recommended in patients with asymptomatic left ventricular systolic dysfunction and the history of prior MI in order to prevent or to delay the onset of heart failure and to prolong life. And this is a class 1 recommendation. Also, ACE are a class 1 recommendation in asymptomatic left ventricular systolic dysfunction without history of myocardial infarction in order to prevent or delay the onset of heart failure. And it's a class 2A recommendation to use ACE inhibitors in patients with stable coronary artery disease, even if they do not have left ventricular systolic dysfunction, in order to prevent or delay the onset of heart failure. So in asymptomatic patients, still ACE inhibitors are class 1 recommendation to be used if the patient is having prior MI or patient without prior MI, and in patients with normal LV systolic function, it is recommended to give them ACE inhibitors as a class 2A recommendation to prevent or delay the onset of heart failure. And in patients with symptomatic heart failure, the story is different a little bit nowadays. We have to give our patients, as we all know, it's diuretics to relieve the symptoms and the signs of congestion. And if the ejection fraction of the patient is reduced, we have to start with ACE inhibitor and the beta blocker and up titrate to the maximum tolerated evidence-based dose, and this is very important, to up titrate to the maximum tolerated evidence-based dose. And if the patient is still symptomatic, we have to add a mineralocorticoid receptor antagonist, and if the patient is still symptomatic, we have either to shift from ACE inhibitor or ARBs to an ARNI. If the patient is having tachycardia, we have to add ivabradine, and if the patient is having white QRS with sinus rhythm, we have to propose for the patient CRT. And still, in the guidelines, ACE inhibitor is recommended in addition to a beta blocker for symptomatic patients with heart failure to reduce the risk of heart failure, hospitalization, and death, and it is a class 1 recommendation. ARBs, when they are indicated according to the guidelines, ARBs are recommended to reduce the risk of heart failure, hospitalization, and cardiovascular death in symptomatic patients unable to tolerate an ACE, patients who also receive a beta blocker and mineralocorticoid receptor antagonist. So if the patient is ACE intolerant, we can shift to an ARB. And the role of the angiotensin receptor neprilysin inhibitor, the ARNI, sacubitril valsartan, is recommended as a replacement of ACE inhibitor to further reduce the risk of heart failure, hospitalization, and death in ambulatory patients with heart failure with reduced ejection fraction who remain symptomatic despite of optimal medical therapy with an ACE inhibitor, a beta blocker, and a mineralocorticoid receptor antagonist. We cannot, in 2020, neglect the importance of the introduction of the ARNI and the improvement of the ARNI as regards the improvement of patient symptoms if the patient is symptomatic despite of ACE inhibitors. What are the optimal doses of heart failure management? According to the guidelines, when you use heart failure treatment, ACE inhibitors and other medications should be up titrated to the maximum tolerated dose in order to achieve the adequate inhibition of the renin, angiotensin, aldosterone system. And there is evidence that in clinical practice, the majority of patients receive a suboptimal doses of ACE inhibitor. Still in our country, we can see patients with heart failure receiving ramipril 1.25 milligram once a day or 2.5 milligram once a day, and this is a suboptimal dose. And in the European Heart Journal in 2017, they have the guidelines, they have a statement that despite the clear guidelines, most patients with heart failure and reduced ejection fraction do not attain the guideline recommended target doses. And we all know the target dose for ACE inhibitors. If we are using captopril, we have to use up to 50 milligrams 3 times per day. Enalapril, 20 milligram. Lisinopril, up to 35 milligram once daily. Ramipril, we have to reach the 10 milligram dose, and trandolapril, 4 milligram once daily dose. This is according to both European guidelines and the American guidelines. And you have to reach the proper dose. For example, if you are going to use an ARB, candesartan, you have to use up to reach the 32 milligram, losartan 150, valsartan 160 milligram twice a day. And if you are using an RNA sacubitril valsartan, the aim and the target dose is to reach 200 milligram twice a day. According to a randomized clinical trial, does it really differ if we are going to use the proper dose or if we use a suboptimal dose? This is a determinant of clinical outcomes of up titration of ACE inhibitors and beta blockers in patients with heart failure. It's a prospective European study, and it shows that if you are going to up titrate the dose of beta blockers and ACE inhibitors up to a recommended dose according to guidelines, they found that if you are using a dose less than 50% of the recommended dose, you have a mortality rate with use of ACE-ARB of 25%, a mortality rate 25%, and the mortality and heart failure hospitalization of 39%. But if you use the proper dose, more than 50% of the recommended dose, you can reach the mortality rate of 14% versus 25%, and the mortality and heart failure hospitalization 29% versus 39%. This is for the ACE and ARBs. The same for beta blockers. If you are going to use 50%, you have a mortality of 22%, and if you use a proper dose, you can reduce the mortality by 16%, so there is an absolute reduction of 6% by the proper dose, and the heart failure hospitalization and mortality 36% reduced to 31% if you use a proper dose. So when you use a proper dose of RAS blockade with an ACE on ARB or a beta blocker, more than 50% of the recommended dose, you can reach a proper reduction of mortality and a proper reduction of heart failure hospitalization. And this is clear in both graphs when you use a proper dose of ACE inhibitor, ARBs, or a beta blocker, versus if you use less than 50% of the recommended dose, you have a higher mortality. So the conclusion of this study is that patients with heart failure and reduced ejection fraction who were treated with less than 50% of the recommended dose of ACE inhibitor, ARB, and the beta blocker seem to have a greater risk of death and or heart failure hospitalization compared with patients reaching 100% of the dose. And in Circulation Heart Failure Journal, there is another meta-analysis published, and the objective was to investigate the effect of the dose of ACE and ARBs on the outcome and drug discontinuation in patients with heart failure and reduced ejection fraction. And the conclusion was in patients with heart failure and reduced ejection fraction, compared with a lower dose, higher dose of ACE and ARB significantly saw modest improvement of the composite endpoint of all-cause mortality, heart failure hospitalization, and without significantly increasing the chance of discontinuation. This is reflected upon the last update of the European Society of Cardiology in 2019, the clinical practice update of heart failure in 2019. There are two important statements. The first, that there is a network meta-analysis, the most effective combination for heart failure with reduced ejection fraction, where sacubitril valsartan plus a beta blocker plus mineralocorticoid receptor antagonist. 2, ACE inhibitor plus beta blocker plus mineralocorticoid receptor antagonist plus ivabradine, leading to a reduction in all-cause mortality versus placebo of 62% and 59% respectively, and all-cause hospitalization 42% of each combination. So if you are going to use a proper dose of an ACE plus a beta blocker plus ivabradine plus mineralocorticoid receptor antagonist, you can reduce the mortality by 59% and you reduce the heart failure hospitalization by 42%. If you up titrate or if you change to an ARNI instead of an ACE, the benefit will be more 3% reduction in the all-cause mortality, 62% relative risk reduction versus 59%. And the second statement, which is very important from the updates and the consensus of European Society of Cardiology, is the importance of the adherence to the proper dose of ACE, ARB, or beta blockers in our patients. In the qualified survey, international prospective observational longitudinal survey among around 7,000 patients with heart failure and reduced ejection fraction, after a recent heart failure hospitalization, good adherence for treatment with an ACE, ARB, beta blocker, mineralocorticoid receptor antagonist, ivabradine, with the prescription of at least 50% of the recommended dose, which, however, is still less than what is achieved in many trials, was associated with better clinical outcomes and during 6 months follow-up and reduced mortality. The same, the Biostat congestive heart failure study, which was specifically designed to study the up-titration of ACE, ARB, and or beta blocker, and enrolling 2,516 patients with worsening of heart failure. Those treated with less than 50% of the recommended dose have greater risk of death and or heart failure hospitalization. So what we have learned from the guidelines, you have to follow the guidelines to give our patients the proper dose in order to reduce the heart failure hospitalization, to reduce heart failure mortality. As regards ramipril is what were the ramipril doses used in clinical trials for heart failure? As we all know, there are multiple clinical trials investigating RAS blockade in the setting of heart failure. The HOPE and the AIR are one of the most important trials addressing the use of ramipril in the setting of high-risk patients or patients with heart failure. And in the HOPE trial, as we all know, it's studying the effects of ACE inhibitor ramipril on cardiovascular events in high-risk patients. And all of us knows that in the primary outcomes, there is more reduction of the cardiovascular death, stroke, and MI, with a relative risk reduction of 22%, and development of heart failure was reduced by 23%, and there was a low incidence of reported side effects leading to discontinuation of the drug. And the conclusion of the HOPE trial is that ramipril significantly reduces the rates of death, MI, and stroke in a broad range of high-risk patients who are not known to have a low ejection fraction or heart failure. The AIR study, addressing the use of ramipril in acute infarction, ramipril efficacy trial, and it is compared the ramipril with placebo in patients with heart failure and post-MI, and it showed that in patients with heart failure and and ischemic heart disease post-MI, the use of ramipril was associated with survival benefit and reduction, relative risk reduction of the cumulative of 36%. What is the starting dose of ramipril in patients with heart failure? We have to use first 1.25 milligram and then up titrate after 2 weeks to 2.5 milligram, and after 2 weeks up titrate to 5 milligram, and last you have to up titrate to reach the target dose of 10 milligram in order to reduce the dose. What is the ideal up titration methods for heart failure management? And this is the consensus document on the ACE inhibitors in cardiovascular disease published in the European Heart Journal in 2004, and it showed us how we have to up titrate the dose of ACE inhibitor in patients with heart failure. Who should receive ACE inhibitor? All patients with heart failure or symptomatic left ventricular dysfunction must receive a RAS blockade without contraindication for ACE inhibitor, and with caution in patients with significant renal dysfunction, patients with a serum creatinine level more than 2.5 milligram per deciliter, or hyperkalemia, or symptomatic hypotension, or drug interaction to look for if they are using potassium supplement, potassium sparing diuretics, and high potassium content non-steroidal anti-inflammatory or angiotensin receptor blocker. When to start? As soon as possible. As we said, starting dose, we've previously said the starting dose for most of the ACE inhibitor, we have to start with a low dose, double the dose at 2 weeks interval, faster titration in asymptomatic left ventricular dysfunction, mild heart failure, hypertensive in hospitalized patients. We can go more rapid than every 2 weeks interval to up titrate. And the aim is the target dose according to the guidelines or the highest tolerated dose for this individual patients. The monitoring is very important after giving an ACE inhibitor or an ARB with diuretics and mineralocorticoid receptor antagonist. We have to revise the clinical status, the blood pressure, the renal function, the serum creatinine and the serum potassium level. They inform the patients about the benefits of the treatment and advise the patient to report adverse events if there is dizziness, symptomatic hypotension or cough. What to do if there is a worsening of the renal function? We are usually anxious about deterioration or rise in the renal function in patients with impaired renal function in whom we are going to start RAS blockade. If the elevation of serum creatinine level less than 3 milligram per deciliter or a potassium less than 6, rise is expected at the beginning of treatment. No action if it's small and asymptomatic. You have to continue monitoring. Reconsider stopping concomitant nephrotoxic drugs such as non-steroidal anti-inflammatory, potassium supplement, potassium sparing diuretics. If there is no signs of congestion, reduce the dose of diuretics. And if we have a high serum creatinine level or potassium persist, half the dose of ACE, recheck, and if still there is a rise and not declined, you have to stop. So my take-home message from today is that despite the clear guideline recommendations, most heart failure patients and reduced ejection fraction do not attain the guidelines recommended target dose. The same as the control of hypertension in our country, most of our hypertensive are not reaching the target blood pressure. Most of our patients with heart failure, they are not receiving the proper dose of ACE inhibitors and the other medications. There is a lack of health provider awareness and poor communication of medication plan between the acute and primary care will remain the main challenge. We have to inform most of our physicians, especially the internists, sharing the treatment of patients with heart failure with us, the importance to follow the guidelines. More than 75% of patients tolerated the target dose in randomized clinical trial regardless of the presence of hypertension. And you have to remember usually that our aim is a target dose. If you are using an ACE inhibitor, an ARB or an ARNI, you have to reach the target dose or the highest tolerated dose in order to get the benefit of reduction of heart failure hospitalization and reduction of mortality. Thank you.
Dr. Mohamed, for this elegant presentation. First, I want to ask about the American Heart Association 2020, a few days ago, recommend for patients with HFrEF to go with ARNI, beta blocker, MRA, and SGL2 inhibitor. What about this recommendation of AHA?
As I said in the beginning of my presentation, in this presentation I'm not saying that we have to use an ACE instead of using an ARNI. We have to follow the guidelines. The guidelines first, they said start with an ACE, and then if the patient is still symptomatic, you have to shift to use an ARNI. The last guidelines of the American Heart Association, American College American Heart Association is changing, and this is expected because of the marvelous benefit of the use of an ARNI in patients with heart failure. But still in our country, some of the patients cannot financially have the access to have an ARNI. In these patients, when you are going to use an ACE or an ARB, you have to follow the guidelines as regards the proper dose and to reach a proper target dose in order to reduce the mortality.
Mohamed, do you expect that the new guidelines for heart failure, which will be about 1 year later, will change for this area, ACE, ARB, ARNI? Because the last heart failure 4 years ago. Do you think the next guidelines for heart failure will be changed?
I think the European Society guidelines, the last European Society guidelines are published in 2016. The update, the consensus was in 2019 and was still having the same recommendation as 16. Some modification, some little modification about the use of the drugs, but otherwise there is no difference. But I think that the next, what is expected in the next guidelines of the European Society of Cardiology, I think it's going to change to use an ARNI. And even there's a statement, they have, in 2019, they have two statements, ARNI plus beta blocker plus mineralocorticoid receptor antagonist or
yes.
RAS blockade plus beta blocker plus mineralocorticoid antagonist plus ivabradine to reduce heart failure hospitalization and improve mortality.
Excuse me, I have a question
understand
for
what you say.
Professor Loutfi. Do you hear me?
Recommendation
Hello?
something and guidelines another story.
دكتور
في تاسك فورس
صب.
وفي فاست تراك وفي anything في consensus. Till now, just a recommendation, it could be one of the 4 pillars or 5 pillars. من البيلرز اللي هم البيتا بلوكرز as you know النيرالوكورتيكويدز والارني والاس جي ال 2 والنيو دراجز اللي هو الكونتراكتيليتي زي جالاكتي هارت فيلير I think ان كمان الانتروبس are coming there. But still now, still ACE or ARBs, if this fails يبقى ارني. احنا محمد speaking about the strict the last year. يمكن الامريكان even today يعني الارني early. بس اليوروبيان not yet. My question to you محمد before احمد شاور. الايس انهبيتور او الراميبريل ليه مش واخد حقه؟ يعني شايف انت يعني why the ramipril itself يعني ramipril اللي هو الفاذر اوف the ACE inhibitor والdifferent trials ويمكن في البوست مايكارديال انفارشن patients موجود في البيشنتس عندهم acute chronic syndrome اكتر من الكرونيك ستيبل. كرونيك ستيبل ماني بيرندروبريل يمكن كانت في الجايد لاينز. والهارت فيلير يعني هو زي ما انت قلت اب تايتريشن لغايه ما ماكسيمم دوز. ايه الديس ادفانتج ان نوت يوز الراميبريل؟
هي مش disadvantage على قد ما هي everything in the if there is no new updates in the data as regard no recent studies involving patients on ramipril in patients with heart failure. Most of the new data are coming from the use of an ARNI in patients with heart failure. Plus, when you are going to compare, there is in every field in medicine there is you can be pushed by the industry sometimes towards one drug over the other drug. So if you are going to say, for example, when we are going to see as something like trimetazidine and the nitrates, they are pushing trimetazidine, no one is pushing nitrates. No one is pushing nowadays ACE or ARBs in heart failure as the ARNI as regards the industrial support of the trials and the data.
So cheap drugs.
Yes, I think in developing countries, in patients who cannot afford to receive an ARNI, I think that the best treatment for him, according to the guidelines, to use an ACE inhibitor plus a beta blocker, the proper dose of an ACE, proper dose of a beta blocker, ivabradine, and mineralocorticoid receptor antagonist. This is the cheap combination in order to, in developing countries, in patients who cannot tolerate. In our country nowadays, there is improvement of the medical care. The ARNI are available for patients with health care insurance, and I think that in the Ministry of Health, they are going to propose for the patients. This is very important, but still, we have patients on ACE. We have to follow the guidelines of these patients.
Thank you. Lovely presentation as usual, Professor Mohamed. And I was catching up on Professor Tamer's question about the ARNIs. And let's talk seriously. The ARNI penetration in the world is quite low because of the cost. It's not its effect is there, but the problem is the cost, as you just said, in our developing countries. And something like ramipril, and personally, and I think a lot of people agree, is one of the easiest ACE inhibitor to reach the target dose of 10 milligrams more than others. And there are data now even that giving the highest dose, and you showed us, it's just a 59 to 62% reduction. Adding maybe an SGLT2, which are much cheaper than an ARNI, may help in patients that cannot afford or cannot get an ARNI. So do you think this might be a way of management? I know it's not guideline recommended, but I think it could be economically recommended.
Ahmed, if the using of ARNI, of ACE inhibitor not achieving the target, you will start with ARNI, or was your strategy to add first SGL2?
But SGL2 cannot compensate for the ACE or ARNI. It's another story.
It's an add-on.
It's
an add-on.
It's
Yes.
add-on.
It's an add-on.
ARNI is a substitute, but SGL2 is an add.
Dr. Mahmoud Hassanin, you are with us in the United States.
Yes,
What
I would
about
like to
United
thank
States?
Professor Loutfi for his great presentation, and I believe firmly that we should
cannot hear you,
reach.
please. We cannot hear you.
Can you hear me now? Hello?
Yes.
I think firmly that we should reach the maximal tolerated dose of an ACE inhibitor in order to achieve the reduction in mortality. But you know, most of the doctors, not only in our country, but all over the world, they do use suboptimal doses because they have concerns concerning the hypotension, hyperkalemia, and deterioration of renal function when they increase the dose of an ACE inhibitor. I think Professor Loutfi has addressed many of these problems. Can you just reassure doctors about these side effects and how to avoid them? And I think this is not an excuse not to reach the maximal tolerated dose, which proved to be of benefit in mega trials of heart failure.
So
Even in the ARBs or ARNI, you have to do electrolytes, potassium, creatinine clearance, EGFR, in every patient. Mohammed speak that it's in every case you should do a.
in every patient with heart failure, if you are going to give him an ACE inhibitor, ARB or an ARNI, you have to check first the renal function and serum potassium level before starting your treatment. And if you have a patient with a serum potassium level more than 5.5 and patients with serum creatinine level more than 2.5, you should be cautious when you are going to start. You have to start with a very low dose, and you have to have very close monitoring of the renal function and the serum potassium level. If there is a rise in the serum potassium level less than 50%, the serum creatinine level less than 50%, or no rise in the potassium more than 5.5, I can continue. Otherwise, I have to reduce the dose or to stop.
اعتقد برضه دكتور محمد الحاجات اللي بتمنع من الابتيتريشن اوف رامبريل في الحالات الهارت فيلير اللي هو الهايبوتنشن. انا في حالات الهارت فيلير لو انا بعمل ابتيتريشن فده بيخليني less need to diuretics عامه في الهارت فيلير has no mortality benefits. I must de-escalate ان انا اقلل كمان جرعه الدايوريتكس عشان امنع البيشنت من هو يخش من الهايبوتنشن.
If the patient is not having congestion, yes, I have to use the least effective dose of the diuretics, the least effective, in order to keep our patient dry.
Yes.
Otherwise, some patients you are obliged to use a high dose of diuretics. Some patients you have obliged, especially patients who are still congested despite of the optimal medical therapy with the triple therapy.
Yes. Thank you.
محمد
treatment of heart failure ده عبارة عن زي انت you have a lot in your pockets to give to the patient. Now we have a lot of pillars. يعني away مثلا 10-20 years ago we don't have except 2 or 3. Now we have a lot, and you have to know which drug you give,
Yes.
and how the dose, how to titrate, and how to calibrate for the patient. And you have to listen to the patient, to
Yes.
examine, and through the echo, and everything.
And to incorporate all
Yes.
the items,
Yes.
the clinical status, the presence of congestion, the blood pressure, the renal function, and the symptoms of the patient in order to
Quality of life.
quality of life. So the treatment of heart failure patients and the dose is individualized. The same drugs, you are
Yeah.
going to individualize the dose for each particular patient.
Okay, we want to thank Dr. Mohamed Loutfi for this elegant presentation and want to close this session and go for a short
Thank you
break.
so much.
Thank you very much.